Hello, everyone, and welcome to my presentation for the case study on chronic diseases. For my case study, I am choosing something that hits close to home, and that is chronic kidney disease, also known as CKD. Little backstory: a couple of years ago, my mother was diagnosed with chronic kidney disease, and over the last couple of years, I have witnessed her, through firsthand experience, go through the daily struggles of dealing with the symptoms that come along with the disease. She was diagnosed with stage 3 kidney disease after she had an acute injury from the medications that she had been taking for years. After a brief stint in the hospital for symptoms such as shortness of breath, fatigue, and generalized malaise, it was determined that she had stage 3 kidney disease. The disease is a long-term condition characterized by the gradual loss of kidney function over time. The disease is termed chronic because this damage occurs slowly over months or years, often without noticeable symptoms in the early stages. The disease, while effects on the body are irreversible, the progression can be halted and individuals with the disease can live a healthy, normal lifestyle. Through the next couple of slides, I'll be discussing what the kidneys do, what CKD is, the pathophysiology of the disease, medications and techniques used to manage and treat symptoms of CKD, and how we as nurses can educate patients with CKD. So hang on to your seat and get ready for this educational journey. I think to fully comprehend what CKD is, we must understand what the kidneys do. The kidneys are vital organs that perform several essential functions necessary for maintaining overall health and homeostasis in the body. Below is a detailed breakdown of their primary roles. First and foremost, their primary job is waste removal. The kidneys filter waste products from the blood, which include urea, a byproduct of protein metabolism, creatinine from muscle activity, and various other toxins. These waste products are excreted from the body through urine. The filtration process occurs in tiny functional units called nephrons, where blood is filtered to separate waste from useful substances. In addition, they also have a very big role in fluid balance. Kidneys regulate the body's fluid balance by adjusting the volume of water excreted in the urine. They can conserve water when needed or increase urine output when there is excess fluid in the body. This function helps maintain optimal hydration levels and prevents dehydration or fluid overload, which is often seen within CKD patients. In addition, they help with electrolyte balance. The kidneys help maintain a proper balance of electrolytes such as sodium, potassium, calcium, and phosphorus. They do this by selectively reabsorbing these minerals back into the bloodstream or excreting them in the urine based on the body's needs. This regulation is crucial for nerve function, muscle contraction, and other cellular functions. They also play a pivotal role in acid-base balance. The kidneys play a critical role in maintaining the acid-base homeostasis by regulating the pH level of the blood. They achieve this by excreting hydrogen ions and reabsorbing bicarbonate from urine, thus helping to neutralize acids produced during metabolism. In addition, they help with hormone production. The kidneys produce several important hormones such as erythropoietin, which stimulates red blood cell production in response to low oxygen levels. They help produce renin, which helps regulate blood pressure by controlling fluid balance and systemic vascular resistance, and also calcitrol, the active form of vitamin D, which promotes calcium absorption in the intestines and maintains bone health. In addition to that, the kidneys play a big role in blood pressure regulation through the renin-angiotensin aldosterone system, also known as the ROS system. Kidneys help control blood pressure by regulating blood volume, systemic vascular resistance. When blood pressure drops, renin is released to initiate a cascade that increases our BP. Last but not least, the kidneys also play a vital role in metabolism of vitamin D. The kidneys convert inactive vitamin D into its active form, calcitrol, which is essential for calcium reabsorption from food and maintaining healthy bones. Next, I want to discuss how the kidneys filter blood. This is important for us to understand because when someone has kidney disease, the main component of the disease is that the body is unable to filter as well as it used to due to the damage to the nephrons. So, how do the kidneys filter blood? The kidneys filter blood through a highly organized and efficient process involving their structural units called nephrons. Each kidney contains approximately 1 million nephrons, which are responsible for the filtration of blood and the formation of urine. The filtering process can be broken down into several key steps. First, blood flow into the kidneys. Blood enters the kidneys through the renal artery, which branches off from the abdominal aorta. This artery divides into smaller arterioles that lead to each nephron. Next, filtration at the glomerulus. Each nephron begins with a structure called the glomerulus, a network of tiny blood vessels, capillaries. As blood flows into the glomerulus, it is subjected to high pressure due to the narrowing of blood vessels downstream. This pressure forces water, small molecules such as glucose, salts, and urea, and waste products out of the blood and into a surrounding capsule known as Bowman's capsule. Larger molecules like proteins and blood cells remain in the bloodstream because they cannot pass through the glomerular filtration barrier. Next, formation of filtrate. The fluid that collects in Bowman's capsule is referred to as filtrate. This filtrate contains water, electrolytes, nutrients, and waste products that need to be processed further. Following that is the reabsorption in the renal tubule. After filtration, the filtrate moves into a series of tubules, which consist of the proximal convoluted tubule, loop of Henle, distal convoluted tubule, where reabsorption occurs. Here, essential substances such as glucose, amino acids, and certain ions such as sodium and potassium are reabsorbed back into the bloodstream through active transport mechanisms. Approximately 99% of filtered water is also reabsorbed during this stage. Following that, we have secretion. In addition to reabsorption, certain substances are secreted from the blood into the tubular fluid in this phase. This includes excess ions like potassium and hydrogen ions, and waste products that were not filtered out initially. Next is formation of urine. The remaining fluids after reabsorption and secretion becomes urine. It travels from the renal tubules to collecting ducts where it further concentrated before draining into the renal pelvis. Finally, we have excretion. Urine flows from each kidney down to ureters to be stored in the bladder until it is excreted from the body through the process of urination. And that is how the kidneys work. Now that we have a good understanding of what the kidneys do, I think it's about time that we start getting into CKD and the pathophysiology behind it. But before we do that, I wanted to talk about some facts that really put an exclamation point behind the dangers of CKD. Most people with CKD don't have symptoms in the early stages. This often is referred to as a silent killer. That's because roughly 1 in 3, approximately 40% of adults with severe kidney disease don't even know they have it. About 35.5 million US adults are estimated to have kidney disease. That's more than 1 in 7. We're talking 14%. Kidney disease is the 8th leading cause of death in the US and is often associated with cardiovascular disease. About 360 people begin treatment for kidney failure every day. That's dialysis or waiting a kidney transplant. Approximately 12 people every day will perish while on a waiting list for a kidney transplant. Roughly 1 in 4 Medicare dollars is spent on kidney patients. That's $156.7 billion, and that's only growing. Kidney disease, also known as CKD, causes more deaths each year than breast cancer or prostate cancer. It is a silent killer that is affecting millions of people throughout the country and hundreds of millions of people throughout the world. It is a prevalent disease in our society, and it's only been growing. So over the next couple slides, I look forward to discussing with you the pathophysiology behind it. Now that we have a good understanding of what the renal system does and how it works, we can discuss what CKD is. CKD, also known as chronic renal failure, is a long-term chronic condition compromised of progressive and irreversible deterioration of renal capacity due to slow destruction of renal parenchyma, which is also known as the kidney. The kidneys gradually lose their ability to filter blood. This can lead to a buildup of waste products and fluids in the body, which can cause a variety of different health problems, eventually leading to death when enough nephrons, which is the functional unit of the kidney, have been damaged. The most common causes of CKD are diabetes and high blood pressure. These conditions are the cause of CKD for approximately 74% of those who have the disease. It should also be noted, not that we will go into a lot of detail about it, that if your kidneys stop working suddenly, that's a sign that you have acute kidney failure. Acute kidney failure that doesn't go away is considered chronic kidney disease. Acute kidney failure can come from a variety of different ways, whether it be a traumatic injury or overdose of specific medications that cause damage to your kidneys, can all be causes of acute kidney failure. When it comes to kidney disease, there are 5 different stages. The stage of the kidney disease is determined by the glomerular filtration rate, also known as the GFR, and the presence of kidney disease. Glomerular filtration rate is the measure of kidney function. As chronic kidney disease progresses, GFR tends to decrease. Treatment of chronic kidney disease patients is based on the stage of the disease and the GFR that they are experiencing. I think it's important to fully understand the different stages of kidney disease and what it means. So as I discussed in the previous slide, your eGFR is the determining factor for your stage that you're diagnosed in. And as you can see through the image that I posted, stage 1, you have an eGFR of 90 or higher. It's mild kidney damage. Kidneys work as well as normal. You just might have a little protein in your urine. With this, most people go undiagnosed. Same with stage 2, 60 to 89 eGFR. Kidneys still working well. The damage is mild. Might have a little urine, protein in your urine. But as a whole, it usually kind of goes unpronounced that you're in those things. As you start to get into stage 3, they split it up into 3A, 3B. That's when most individuals start to notice the effects of kidney disease. 60 or lower, they mark stage 3A, 45 to 59, and stage 3B, 30 to 44. This is moderate kidney damage. They're not working as they should. You start to notice some side effects such as shortness of breath, maybe upset belly. You notice that if you eat something, it really affects you. And it affects because your body's unable to process it appropriately. As you start to get into stage 4, you're in pretty severe kidney damage. Kidneys are not close to working well. You're going to have more edema. You're going to have more fluid retention. You're going to feel cardiovascular effects. You're going to start to get on more medication, and your diet's just real crucial. You have to be on a kidney-friendly diet. And the same goes to be said at stage 3 and 2 and 1, but even a bigger exclamation point at stage 4. Stage 5 is, renal failure. You're on dialysis. You're waiting for a kidney transplant. I just wanted to notate that these are important to know to be able to differentiate what patient is which. CKD typically begins with an initial injury to the kidneys. This injury can arise from various causes. This could include diabetes, hypertension, glomerular nephritis, or even acute kidney injury, albeit from a traumatic event such as blunt force trauma to the kidneys, or taking too much medications which causes damage to the kidneys in itself. The nature of the insult can vary widely. For instance, diabetes leads to hyperglycemia-induced damage to the glomeruli, while hypertension can cause vascular changes that impair blood flow and oxygen delivery to renal tissues. During this phase, there may be identifiable damage at the cellular level. For example, Podocytes, which are the cells in the glomerulus, may become dysfunction or lost due to high glucose levels or an inflammatory process. This initial injury triggers a series of biological responses aimed at repair but can inadvertently lead to further nephron damage. And that is because the body likes to compensate, as we all know. As nephrons are injured or lost due to the initial insult, compensatory mechanisms are activated within the remaining nephrons. These mechanisms include hypertrophy, which would be enlargement, and hyperfunction or increased activity of surviving nephrons. The goal is to maintain overall kidney function despite the loss of nephron mass. However, these compensatory adaptations come with significant metabolic costs. The remaining nephrons must work harder and harder and harder to filter blood and excrete waste products. This leads to single nephron glomerular filtration rates being increased. While this initially helps maintain a GFR, over time it can result in further damage due to factors such as lack of oxygen, or oxidative stress from reactive oxygen-specific species generation, and inflammation within the renal interstitium. As more nephrons become dysfunctional or die off due to ongoing stressors, whether from systemic conditions like hypertension or local factors such as ischemia, the ability of remaining nephrons to compensate diminishes. This creates a vicious cycle. Nephron loss leads to increased workload on remaining nephrons, which in turn leads to further nephron injury and eventual loss. This relationship between nephron number and kidney function is often described as linear until a critical threshold is reached where compensatory mechanisms fail. At this point, GFR declines progressively with time as more nephrons are lost without any significant recovery or intervention. So we just talked about how the initial injury can cause damage to the kidneys. Next thing that we're going to talk about is what happens when the kidneys are injured. So glomerular sclerosis, which is the scarring or hardening of the glomeruli, the tiny filtering units in the kidneys, this condition occurs as a result of prolonged damage to the kidneys, often due to underlying conditions, as we discussed before, such as diabetes and hypertension. So initially, you have to have that initial injury. After that initial damage is done and the kidneys start compensating, what happens is you get progressive scarring. Over time, due to the nephrons compensating for the ones that have already had death, it leads to an increase in inflammation and subsequent scarring or sclerosis of the glomeruli. As more glomeruli become scarred, their ability to filter blood effectively diminishes. This leads to further kidney dysfunction. Some things that the patients may experience with this are pronatremia, which is excess protein in the urine. And in addition to that, they might have swelling and an elevated blood pressure due to the inability to filter the blood appropriately and to hold on to unneeded ions such as sodium. If left untreated, glomerular sclerosis can progress to end-stage renal disease, ESRD, which will require dialysis or a kidney transplant. Treatment focuses on controlling underlying conditions like diabetes and hypertension, and using medications such as ACE inhibitors or ARBs to reduce the pronatremia and protect the kidney function from sclerosis. So while you can have glomeruli injuries, you can also have tubule injuries of the kidneys, which also cause CKD. A tubule injury has a different cascade than your glomerular sclerosis, though. In a tubule injury, it starts with the epithelial to mesenchymal transition, also known as an EMT for short. A key mechanism driving tubular interstitial fibrosis is the EMT. In this process, tubular epithelial cells lose their characteristics and transform into myofibroblast-like cells that contribute to fibrosis. EMT is stimulated by several factors, including proteinuria, and hypoxia, which are both very common in CKD. Next step is inflammation and cytokine release. Following the initial injury, there is an inflammatory response characterized by the recruitment of immune cells such as macrophages. These cells release pro-inflammatory cytokines and growth factors like transforming growth factor beta 1, TGF-B1, which play a pivotal role in promoting EMT and fibrogenesis. Next is the fibrosis development. TGF-B1 activates signaling pathways that enhance collagen production and other extracellular matrix components, leading to increased fibrosis within the renal interstitium. This acclimation of fibrotic tissue disrupts normal kidney architecture and function. Following that, we have a feedback loop of injury. The presence of fibrosis created a feed-forward cycle where increased interstitial pressure due to scarring further compromises blood flow and oxygen delivery to renal tissues, exacerbating hypoxia and promoting additional tubular cell injury. This cycle perpetuates kidney damage even after the initial insult has resolved. Last is your loss of nephron function. As tubular interstitial fibrosis progresses, it leads to a decline in nephron function due to both direct effect on tubules and indirect effects through impaired vascular supply. The remaining healthy nephrons may undergo compensatory hyperinflation initially. However, this compensatory mechanism eventually fails as more nephrons become damaged or lost, leading to failure of the kidneys. As CKD progresses, it can lead to multiple systemic complications that affect overall health, such as the cardiovascular system. CKD significantly impacts cardiovascular health. The kidneys help regulate blood pressure and fluid balance. When they are compromised, patients often experience hypertension. This condition can lead to LVH, heart failure, and increased risk of cardiovascular events such as strokes and heart attacks. In fact, individuals with CKD have a markedly higher incidence of cardiovascular disease compared to those without kidney impairment. The underlying mechanisms include hypertension due to fluid overload and activation of renin-angiotensin-aldosterone system. Dyslipidemia, altered lipid metabolism, leads to increased levels of low-density lipoprotein, also known as LDLs, which is essentially your cholesterol. In addition, atherosclerosis, accelerated vascular clarification, and endothelial dysfunction contribute to plaque formation in arteries. In addition to cardiovascular problems, it also affects your hematologic system. It affects the production of erythropoietin, a hormone produced by the kidneys that stimulates red blood cell production in the bone marrow. As kidney function declines, erythropoietin levels decrease, leading to anemia characterized by fatigue and weakness, and an increased risk, again, of cardiovascular events. Anemia can exacerbate existing cardiovascular conditions. In addition to that, mineral and bone disorders. The kidney plays a vital role in mineral metabolism, particularly calcium and phosphorus balance. In CKD, hyperphosphatemia, reduced phosphate excretion leads to elevated serum phosphate levels. Also, hypocalcemia, impaired conversion of vitamin D into its active form, results in decreased calcium absorption from the gut. Lastly, secondary hyperparathyroidism, elevated parathyroid hormone, PTH, levels occur as compensatory response to low calcium and high phosphate levels, leading to bone disease known as renal osteodystrophy. Next, metabolic acidosis. As kidney function declines, the ability to excrete hydrogen ions diminishes, resulting in metabolic acidosis, characterized by decreased bicarb levels. This can lead to muscle wasting and bone demineralization and compensatory mechanisms. increased respiratory rate as the body attempts to expel carbon dioxide. In addition to that, we have a neurological effect. Patients with CKD may experience neurological complications due to uremic toxins accumulating in the bloodstream, cognitive impairment, such as difficulty concentrating or memory problems, and peripheral neuropathy, numbness or tingling sensations due to nerve damage from metabolic disturbances. In addition to that, we have gastrointestinal system problems. CKD impacts your gastrointestinal health. It does this through nausea and vomiting. Oftentimes, individuals with CKD complain of feeling nauseated. An accumulation of waste products can irritate the GI tract. In addition to that, they can experience a loss of appetite and weight loss. Common symptoms that arise from uremic syndrome. Last but not least, we have an immune system dysfunction. Individuals with CKD are at an increased risk for infection due to immune system impairment caused by uremia. Altered immune response, increased susceptibility to infections such as pneumonia or UTI infections. In summary, chronic kidney disease has a profound effect on multiple organ systems due to its role in regulating essential bodily functions like fluid balance, electrolyte, homeostasis, blood pressure regulation, red blood cell production. Understanding these systematic effects is crucial for managing patients with CKD efficiently. Next, I want to discuss on the causes of kidney disease. What causes all these different pathophysiological changes? The two most common causes of CKD are diabetes and hypertension. This accounts for 74% of individuals who have CKD. Diabetes can lead to chronic kidney disease through several mechanisms. First, high blood sugar levels can damage the tiny blood vessels in the kidneys, specifically affecting the nephrons, which are filtering units of the kidneys. Over time, these vessels can become narrow and clogged, which then reduces blood flow and leads to kidney damage. From being clogged, it increases the blood pressure, right? Elevated blood pressure also harms the kidneys and affects the ability to filter waste effectively. Next is protein leakage. Diabetes creates protein leakage. As kidney function declines due to damage from the diabetes, proteins such as albumin may leak into the urine, a condition known as albuminuria, indicating that the kidneys are not functioning properly or unable to filter stuff appropriately. Diabetes can cause nerve damage that affects bladder control. If the bladder does not empty completely due to the nerve issue, it can lead to urinary tract infections. And not only does the bladder not emptying appropriately, affect the individual and create a tendency for them to get UTIs, but high glucose levels, high sugar levels also promote bacterial growth, increasing the risk of UTIs that can ascend into the kidney, and this can cause additional damage. So overall, as a whole, diabetes really affect the kidneys in a harsh manner. In addition, we have hypertension. High blood pressure, hypertension can lead to chronic kidney disease through several mechanisms as well. First and foremost, it's damage to the blood vessels. Hypertension causes the blood vessels in the kidneys to constrict and narrow. This narrowing reduces blood flow to the kidneys, impairing their ability to filter waste from the blood effectively. In addition, it increases pressure on the kidneys. The elevated pressure from hypertension puts additional strain on the delicate structures within the kidneys, particularly the glomeruli, which are responsible for filtering the blood. Over time, it can cause glomerular sclerosis, as we talked about earlier from the pathophysiology slide. It also affects the cycle of damage as kidney function declines due to damage from high BP. The kidneys become less effective at removing excess fluid and waste. This inefficiency can lead to further increases in blood pressure, creating a vicious cycle that exacerbates both hypertension and kidney damage, which seem to go hand in hand. And lastly, progression to CKD. Continuous damage from uncontrolled hypertension can lead to the scarring and loss of the functional kidney tissue over time. As I talked about before, it can cause glomerular sclerosis, which ultimately results in CKD disease. Continuing on the causes of CKD, I think we have a couple other important ones that I just wanted to touch on. Glomerular nephritis is a condition that leads to scarring and damage through inflammation of the glomeruli. You have polycystic kidney disease. This is a genetic disorder characterized by the growth of numerous cysts in the kidneys. These cysts can enlarge over time, leading to increased pressure within the kidneys and progressive loss of kidney function. You have acute kidney injury. This can be due to a disease. This can be due to toxins, hydration levels, severe infections. It's even seen in flow disruptions, such as like tumors that might enable someone to use the bathroom. That buildup from pressure can cause acute kidney injury. You have traumatic injuries such as blunt force trauma from car crashes that can cause an immediate damage to the kidneys, which over time will result in chronic changes. Uh, and also genetics play a real big role. There's a bunch of different hereditary nephropathies that increase the risk of developing CKD. So I just want to say and mention these because I think it's important to notate them. Next, let's discuss the signs and symptoms to look out for in each stage of kidney disease. Stage 1 and 2, they're pretty similar. You're probably going to be asymptomatic. There may be signs of kidney damage detectable through laboratory tests, and you might have some protein in your urine and be hypertensive in these stages, but overall you're gonna be pretty asymptomatic. Stage 3, when your EGFR is between 30 to 59, is when the symptoms become more apparent as kidney function declines to mild to moderate levels. Individuals begin to experience swelling, aka edema, particularly in their hands, legs, feet, or ankles due to the fluid retention from their nephrons not working as appropriately. They're going to be more fatigued, the general feeling of tiredness or weakness, changes in urination habits. The individuals are going to be urinating more frequently or less than normal. Kidney pain, discomfort felt in the lower back area, and hypertensive as well. Can become a little anemic during this phase, and you might see some bone disease starting to pop up as well. Stage 4, the kidneys are now severely damaged and leading to more pronounced symptoms such as severe swelling. You're gonna notice swelling and fluid retention all throughout. Significant fatigue and weakness. Your daily activities, the most basic stuff, can be exhausting. Persistent hypertensive. You're gonna have to really pay attention to it. It's where specific medications are gonna be important. Kidney pain is gonna be more intense. That discomfort in the back region is gonna be more present. And additional symptoms might include changes in your urination patterns and increased risk of cardiovascular issues such as tachycardia or maybe AFib. Stage 5 indicates kidney failure. Your EGFR is less than 15. Daily functioning is challenging. It's hard. It's hard to stand up. Some days you're not going to be able to. Severe edema, you're going to have fluid overload daily. It's why these individuals are on dialysis because they can't handle the fluid. Nausea and vomiting, it's a result from toxin buildup in the bloodstream. And you might have that in 3 and 4, but it's going to be present in 5. It's going to be a daily problem. Loss of appetite, weight loss due to systemic effects on the health. And, due to the retention of specific stuff, specific minerals in your body, confusion or difficulty concentrating is going to be profound. Difference in stage 5, it's something that can be present due to the metabolic imbalances. These patients will require dialysis, as I said, or a kidney transplant for survival. So diagnosis of CKD is done through a multi-step process. First and foremost is your initial assessment. Your PCP is gonna do a routine medical examination, especially with those who have certain symptoms, such as weight loss or poor appetite, swollen ankles, feet, hands, shortness of breath, tiredness, increased urination frequency. This kind of puts people on the radar that, hey, they might have a problem with their kidneys. There's also a risk factor evaluation. So certain populations are at higher risk of developing CKD. Regular testing is recommended for those individuals. They are those with high blood pressure, diabetes, history of acute kidney injury because recurrent kidney problems are more common. Cardiovascular disease, conditions affecting the kidneys such as kidney stones or lupus, a family of advanced CKD or inherited kidney diseases, and protein or blood in the urine without a known cause. Additionally, individuals from certain ethnic backgrounds, such as Black or South Asian populations, tend to be at an increased risk for CKD. Uh, Blood tests are the main diagnosis procedure for those with CKD. The primary blood test used to diagnose CKD measures the level of creatinine in the blood. Creatinine is a waste product produced by a muscle metabolism and is normally filtered out by healthy kidneys. Oftentimes, when you're talking about the EGFR, it's the percentage of creatinine in the blood. So when we talk about those below 15 is end stage, renal failure. That's what they're referring to, is that specific blood test. They also have urine tests, such as the albumin to creatinine ratio, the ACR. This test measures the amount of albumin, which is a protein relative to creatinine in urine. Normal levels are less than 3 mg per mmol. Levels above this indicate potential kidney damage. They also have a dipstick test. It's a simple test where chemically treated strip detects proteins like albumin and other abnormalities such as blood. It can help determine if you're having some type of kidney damage. Lastly, there's some imaging studies, right? You can do an ultrasound scan, an MRI. It can visualize the kidneys to check for structural abnormalities or blockages. You could also do a kidney biopsy, although farther down, on the list of things that you're probably going to perform. A small sample of kidney tissue for microscopic examination to identify specific types of kidney damage is sometimes what the doctor will request. There's a variety of different treatments for CKD, but it's more about managing your symptoms because unless you're getting a kidney transplant, there is no cure for CKD. So it's about minimizing, symptoms that might affect your day-to-day lifestyle. And what better way to do that than through food? So a kidney-friendly diet, also known as a renal diet, is a good way to help slow kidney damage and improve the overall health in your day-to-day lifestyle. It often limits sodium, phosphorus, and sometimes potassium and proteins, the things that your kidneys are now having trouble filtering out. Um, so choosing low sodium foods and foods labeled with no salt added or sodium free or low sodium are great choices. Try to avoid canned foods, and if you're using them, rinse them out. It's good to limit dairy because it contains a large amount of phosphorus in it. Most dairy products do. Choose low potassium fruits and vegetables such as apples, blueberries, cherries, grapes, pineapple, raspberries, strawberries, watermelon, and honeydew. Um, and the same with veggies like asparagus, carrots, cauliflower. Cauliflower is great for it. Instead of using salt in your food, it's recommended to use more herbs and spices and avoid the processed foods. The most processed foods, such as fast foods, lunch meat, they're high in sodium. You have to avoid those because they will throw everything off. And choose more lean proteins if you're going to eat protein. Although you have to be careful on how much protein you eat. But think lean meat, skinless poultry, eggs, fish. One portion, pretty small, maybe the size of a deck of cards. In addition to that, live a healthy lifestyle, exercise, limit smoking and alcohol, sleeping habits, get 7 to 8 hours of sleep today. Those are all crucial to really, for your body to respond appropriately to um, CKD. Often considered the first line of defense with CKD is angiotensin converting enzyme inhibitors or ACE inhibitors. These could be lisinopril. They are primarily used to control hypertension and reduce proteinuria in patients with CKD. They also help protect kidney function by decreasing intraglomerular pressure. In addition to that, they have shown to reduce the amount of sodium within the body through excretion. Some of the side effects are going to be cough, elevated potassium levels, which is hyperkalemia, low blood pressure, dizziness, and renal impairment. Contraindications would be angioedema related to previous ACE inhibitor therapy and those with bilateral renal artery stenosis. Diuretics are often prescribed to individuals with CKD. Diuretics are a class of medication primarily used to promote the excretion of water and electrolytes through urine. In context of chronic kidney disease, diuretics serve several very important purposes. One of that's fluid management. Patients with CKD often experience fluid retention due to impaired kidney function. This leads to edema and hypertension. Diuretics help reduce this fluid overload by increasing urine output. In addition to that, they can help control blood pressure. As we've talked about before, sometimes that we have fluid overload, it can cause individuals to be hypertensive, and diuretics effectively lower the BP by reducing the amount of fluid within the system. Electrolyte balance, diuretics help manage electrolyte imbalances such as hyperkalemia and hyponatremia, low sodium levels. In addition to that, there's some symptomatic relief, right? You're swelling your legs due to all this fluid retention, and it helps lower that, helps by removing it from your system. There's a couple different types of diuretics. You have loop diuretics. These are often the first line treatment for significant fluid retention due to their potent effects on urine production. Uh, Usually in later stage renal disease, you're going to be using those. And then you have thiazide diuretics. These are for the more mild cases, or they're also used in combination with the loop diuretics for enhanced effects, but you're usually seeing those through, stages 1, 2, maybe 3. And then in conjunction with other ones, you might see a potassium sparing diuretic. Potassium sparing diuretics are just uh, can help prevent potassium loss if you're excreting too much. Some of the side effects of diuretics or electrolyte imbalances, this could be hypokalemia, hyponatremia, hypomagnesemia, and hyperuricemia, which is high uric acid levels, which ultimately can lead to gout. You could have some dehydration, hypovolemia, create some dizziness, um, low blood volume. Sometimes, in some cases, especially if not monitored closely, diuretic therapy may exacerbate renal impairment due to the changes in the endovascular volume and renal perfusion. You could have also ototoxicity. High doses of loop diuretics can cause hearing impairment or tinnitus due to their ototoxic potential. From a contraindication standpoint, you have hypersensitivity reactions that occur to some. You can have some crazy electrolyte abnormalities and also severe renal impairment. If you're not using the bathroom at all, you could be holding on to, it could be ineffective and could cause more damage than good. Another medication that is commonly prescribed to those with CKD is potassium binders. Potassium binders manage hyperkalemia, which is a common and potentially dangerous CKD complication. They do this by binding to potassium in the gastrointestinal tract, preventing its reabsorption into the bloodstream. The primary purpose, as I said, is to reduce the risk of hyperkalemia and its associated complications, such as dysrhythmias. But in addition to that, they also can help manage our daily diet. Most healthy foods have high potassium levels in them, so by taking these medications, you're able to kind of branch out and have a broader diet. Some of the side effects are going to be gastrointestinal issues like constipation, diarrhea, abdominal pain, and contraindications are limited, but there are some, such as severe bowel obstruction and hypersensitivity. Another important medication is erythropoiesis stimulating agents. They're usually used in conjunction with iron to ensure that normal levels of RBC production in the bone marrow happen. Uh, they're usually used to treat anemia, right? Due to when the kidney's not producing enough erythropoietin. Some of the side effects that may be found are hypertension, headache, joint pain, fever, and an increased risk of thromboembolic events if the hemoglobin levels rise too quickly. Contraindications are going to be hypersensitivity reaction to the medication and uncontrolled hypertension. Another medication that we're going to discuss are statins. Statins are pretty commonly prescribed to those individuals with CKD. Statins are often prescribed not only for their lipid lowering effects but also for their potential cardiovascular benefits. Um, Lipid management. The primary purpose of statins is to reduce low density lipoprotein cholesterol LDL-C levels, which can contribute to atherosclerosis and cardiovascular events. In fact, individuals who are prescribed statins are seen to have a 20% less risk of um, having a cardiovascular event. Statins have shown to reduce the incidence of major cardiovascular events, just as I talked about. This not only includes heart attacks, but also strokes. In addition to that, they've also shown to have a lot of anti-inflammatory properties, um, which helps reduce the different systemic effects of CKD. Some side effects are going to be liver enzyme elevations. Statins can lead to elevations in liver enzymes, indicating potentially liver damage. One of the most common side effects includes myopathy, which can range from mild muscle pain, myalgia, to severe muscle damage, rhabdo. Patients with CKD may be at a high risk for these muscle-related issues due to altered drug metabolism and excretion. In addition to that, there's some GI complications that can occur with those on statins, such as diarrhea, nausea, and constipation. Contraindications are going to be acute liver disease, pregnancy and breastfeeding. It can potentially harm the fetal development. Severe renal impairment. Again, if you're not having any urine output, you might want to avoid statins. And of course, hypersensitivity, like all other medications. If you're allergic to the drug, you avoid it. The last thing we're going to discuss is patient education. Um, Oftentimes, patient education is associated with better patient outcomes. And to start with patient education, the individual who is diagnosed with CKD must understand what CKD is. So it's very important that we sit the patient down and we discuss what CKD is, what's happening to their kidneys, as discussed in the pathophysiology slides earlier. They should know what to expect and the systemic effects of what's going on. It's also important to let them know and reinforce the idea that this is, while a lifelong thing that they're going to have to switch from a lifestyle standpoint, it doesn't mean it's the end of their life. Um, with kidney disease, you can halt and slow progression. And it is crucial through patient education that we teach these individuals with CKD how to do that. So we explain to them what CKD is and the signs and symptoms to look out for. In addition to that, what's the cause behind why they have CKD? An example of that is individuals who are hyperglycemic. Hyperglycemia, aka elevated blood glucose levels, damage the small vessels of the kidneys, which causes proteinuria, in addition to increasing difficulty for the nephrons to filter blood because there's less of them due to the damage and the plaque buildup within the vessels. So we must educate the patients on how important it is that they monitor their blood glucose levels so that they don't, in fact, worsen their progression. In addition to that, it's also important that we give them a full understanding of the importance of having a regimen, ensuring that they take their medications at the same time daily, because it helps, again, slow the progression of the disease. Not only that, we also need to educate the patients on what they need to avoid, right? So patients with CKD, with renal impairment, there are certain medications such as NSAIDs that need to be avoided, right? NSAIDs should be avoided because they reduce kidney blood flow. In addition to that, you have many patients with CKD who have hypertension. Patients with hypertension need to avoid certain medications like vasoconstrictors, like Afrin, right? Afrin causes widespread vasoconstriction, more isolated to the nerves, but it still can increase blood pressure as a result. Any increase in blood pressure with a patient who has hypertension and CKD needs to be avoided. So it's important that we educate the patient on the needs and the understanding of medications that they need to take, as well as medications that they need to avoid. Um, Furthermore, education on nutrition is very important. With CKD, dietary needs are very big in uh, causing slowing the progression of the disease. So you need to, as we discussed again in other slides, but to reiterate on it, reduce salt intake, reduce phosphorus intake. So watch out for dairy products. Limit the amount of protein, and when we're eating protein, we need to have lean protein. And there's specific foods that are good for kidneys and specific foods that can have poor outcomes for the kidneys. And giving the patients a guideline of this is very important, and talking to them about how they need to adhere to it and the effects of what happens when we have too much of these different ions in the body is very important. In addition to that, it's also vital that patients with CKD understand that their life isn't over and that they can live a normal life. But the day-to-day tasks such as bathing, walking, helping cook meals, running up and down a flight of stairs, doing laundry, doing these tasks, they can be made a lot more difficult as CKD progresses into stage 4 and 5. With other symptoms that come along with the later stages, it can make our day-to-day hard. So it's very important that we follow and we adhere to all the things that slowed the progression. With that said, we also must instill a healthy mindset because general well-being is often focused and centered around our own headspace. Someone who's depressed might have a little bit more of a difficult time following these guidelines, whereas someone who's happy and who's motivated and who's ready for the change and who's excited for the change, they're going to be more willing to follow these guidelines, and as a result, will lead and live a more normal life. So all of these are key aspects that we must touch on when providing patient education to our newly diagnosed individuals.